Carpal tunnel syndrome. Spend just a little time talking about carpal tunnel, how it bothers people. What is it really? Yeah. How does it bother people, and what should be done?
By far and away the most common thing I see. Most common surgery in America is carpal tunnel release.
Wow.
They say 10% have carpal tunnel syndrome. It's multifactorial, meaning it's probably a little bit genetic, could have a little bit of a metabolic or an endocrine predisposition, such as patients with diabetes. But what it is the median nerve, as it runs down the forearm, enters the carpal tunnel. So that's a wall of basically 3 bones, or sorry, the wall is encompassed of bones, and then a rooftop of a ligament called the transverse carpal ligament. That's a very thick structure. You cannot stretch it, you can't move it, it's very thick.
And everything goes under it.
9 tendons, the strong tendons that flex the fingers, they run through there, and one nerve, the median nerve, sits on the very top. So those tendons, if they swell or collect water, they're going to take up the space. So it's a fight for space. The nerve's going to lose because it's obviously the most delicate flower in this whole mix. So it's basically cutting off the blood flow to that nerve. Like if you fall asleep on your leg and your foot goes to sleep, you get up and you stomp your foot, it's asleep, and then it slowly gets that nerve sensation, that sensation back. Those pins and needles, though, that you feel as it's waking up, that's what a patient with carpal tunnel feels all the time, because no matter what they do,
they can't
shake that out.
So what do you do for it?
We'll start with a brace at night. So oftentimes people will sleep with their wrist flexed. They're pinching the nerve. You straighten the wrist, get the blood flowing through it at night, and it helps. If it no longer gives you benefit, you can try a cortisone shot. The thing I have with a cortisone shot, and again, good studies have shown, you probably don't have good efficacy or long-standing. Maybe at a year's time, 90% return. If it's really significant, patients are having lots of problems, starting to get any atrophy or constant numbness and tingling, I recommend just a release, just making a small incision in the palm, releasing or dividing the ligament. We don't need the ligament. Everyone asks me why we have it. I don't know.
It's there.
But there's no functional need. So you release it, a couple of stitches, moving right away.
Can there be damage done before you release it that doesn't come back, or does it always come back?
Excellent. So when patients come in, the main thing my job is I'm trying to keep this nerve as functional as possible. So if I start to see an area that maybe you're losing some muscle here in the thenar, or the numbness and tingling is more constant, yeah, those nerve fibers don't come back. So if you've already lost those wires, because it's like a coaxial cable with millions and millions of wires, if part of that coaxial cable has been damaged, we're not going to get that back. So I always like to tell patients, we want to get this thing released, and if there are nerve fibers on the border or on the fence, I want to get those back to us. Get that pain that you have at night and during the day and the shaking to go away. But then it's going to take some time to see how many of those nerve fibers will wake back up, because some of those, if they're permanently damaged, will not. And then they'll always have constant numbness and tingling. It's still a successful surgery, but unfortunately, those nerve fibers have already been damaged. We can't get those back.